I have no disclosures to make in relation to this presentation. And since we don't have too much time, I will go straight on to what I was requested to do. I assumed that I was requested to give an overview of where we are with the TB epidemic at the global level and what we are doing to try and confront that epidemic. And that's exactly what I'm going to try and do over the next 20 or so minutes. So let's start with a summary of the global burden of tuberculosis. The most authoritative source of information on the global burden of tuberculosis is, of course, the Global TB Report that comes out every year. I'm sorry, that should be 2017, not 2016. But the numbers haven't changed that much between 2016 and 2017, so it doesn't really matter that much. But in 2016, it was estimated that there were 10.4 million cases of TB, which works out about 140 cases per 100,000 population. 65% of these were male and 10% of them were children. In terms of TB that is associated with HIV, there were about 1 million cases of TB, which forms about 10% of the total burden of TB. And unfortunately, 74% of those cases are in sub-Saharan Africa. We now have two levels of drug resistance that are reported to the WHO. We report rifampicin-resistant cases alone, and we also report multi-drug resistant TB cases. And the estimate is that they are, in my view, those are basically the same because they are treated in the same way. So nearly 600,000 people had MDR-TB in 2016. Tuberculosis caused 1.7 million deaths in 2016, including about 400,000 cases of people who had both HIV and TB. Over the years, we have noticed a discrepancy between the estimated incidence of TB and the number of TB cases that are notified, with a gap of about 4.1 million cases that are called the missing cases of tuberculosis. In the African region, the situation is the same. We are seeing a decline in HIV-associated, a slight decline in HIV-associated TB, and we are seeing a very small decline in the incidence of tuberculosis since about 2006 or so. A very slight decline in the incidence of TB on a year-by-year basis. Africa has, WHO now gives us three big groups of people with TB, those who have TB alone, those who have TB HIV, and those who have both TB or MDR-TB. And if you look, there are many countries that have all sorts of intersections in there. And the African continent has a lot of countries in there that have all these things. They have high burdens of TB, high burdens of MDR-TB, and high burdens of TB and HIV. I think many of us understand the things that are driving the global burden of tuberculosis. The major one, of course, is poverty. And some people have tried to dramatically present this information on the burden of TB. These are maps that are done to look at, instead of looking at landmass or population sizes, these are looking at proportion of people in those continents who are poor and the proportion of, or rather the burden of TB in those countries. And you can see that they are very, very matched. If you look at the Americas, for example, that map is very thin, a very, very low proportion of people who are poor in those countries. And consequently, if you look at the burden of TB in the Americas, it is equally thin. But if you come to Africa, the proportion of people who are poor is large, and we also have a balloon burden of TB in the African continent. So basically, the major driver of tuberculosis in the world today remains poverty, with all the consequences of poverty that many of us in this room are very familiar with. HIV and tuberculosis, I don't think I need to belabor this point. It's an extremely important driver of TB, especially in the African continent. And many of us will remember this situation beginning about 1990, where in many parts of the world there was a decline in case notification and TB incidence. But in the African continent, before the advent of ART, the rates of TB were growing exponentially. This was the report of the WHO in 2009 that really showed very dramatically what was happening to TB in the African continent, driven primarily by the HIV problem. But there are new things that we need to worry about, and one of those is diabetes mellitus, a major problem now in the world. I am told that this illness has increased a great deal over the last 30 years by more than 20%. It's rapidly increasing in low and middle income countries, and apparently in the next few years, 80% or more of the cases of diabetes will be in low and middle income countries, including Africa. People have looked at the association between tuberculosis and TB, tuberculosis and diabetes mellitus, and at this moment it's thought that the risk of TB in diabetics is almost close to that in HIV-infected individuals. So diabetes increases the risk of TB by a factor of 3, and therefore we all need to be aware that we will have a big problem of TB among diabetics. That may be the next wave of TB in the world, and this is a big problem, especially in countries in Southeast Asia, for example. Tuberculosis and mining. We are a mining continent. A lot of countries in Africa are currently involved in some form of mining, one thing or the other, and mining is a major risk factor for tuberculosis for a number of reasons. Dust exposure in the mines, social conditions outside the mines, risk factors like HIV and tobacco smoking, and of course access to healthcare services, especially for those people who work in the mines and are considered illegal miners or illegal labor migrants. That's a major problem, especially in Southern Africa. So what are we doing to confront the problem of tuberculosis at this moment in time? We should learn from those who have been there before. 1905, I am told this is the lecture that the fellow who discovered Mycobacterium tuberculosis gave after being awarded the Nobel Prize in Physiology or Medicine. And he highlighted the key things that we should do at that time to confront tuberculosis. And these things are still relevant today. The need to address transmission, focusing on infectious cases of TB, the need to address infection control, managing expectoration. They thought if you're going to cough and spit everywhere, that was bad, and if your clothes were dirty and all those kind of things. The need to be in well-lit and aerated rooms, avoiding overcrowding and rapid identification of cases and isolation. The obligation to report, accurate diagnosis. Of course, at that time, the issue was about the sanatoria and what you can do in the sanatoria, social support systems, creating public awareness, and financing the response. And these things are still relevant today. In fact, I would say they are the pillars of TB care and prevention at this moment in time. So Robert Koch said it more than 100 years ago. We have, based on those principles, evolved in our strategies for controlling tuberculosis, from the DOTS strategy after the announcement by WHO of TB as a global emergency. We then realized that it wasn't going to do the job, and we came up with the Stop TB strategy and with the Sustainable Development Goals that came up in beginning 2016, we now have the NTB strategy, which has an extremely ambitious targets of reducing the number of TB deaths by 95% by 2035, reducing the incidence of TB by 90% by 2035, and by ensuring that no families or people suffering from TB suffer catastrophic costs. And this is supposed to be achieved by 2020. So what are the TB care and prevention problems that we need to pay attention to? And there are several of them that I'm going to try and highlight over the next few minutes. The first one is that tuberculosis case finding is not matched with the estimated incidence, and I've already told you that there's a gap of about 4 million cases of TB that are not known at this moment in time, and that gap needs to be filled. The second problem is that the decline in TB incidence is too slow. And this is what WHO has told us, that if you look at the red dotted line, that's where we are going with TB incidence. Our TB incidence is dropping at a rate of less than 1.7, 1.5% per year. And if we are going to follow that trajectory, we will never be able to end TB by 2030. We will definitely not end it by 2050. We will probably require another 100 years before we manage to control this disease. So we need to accelerate the reduction in TB incidence by doing a number of things that are highlighted there. Then we have the problem of high TB deaths. At this moment in time, we have already said 1.7 million people are dying. The case fatality ratio, which is the proportion of incident cases that die, is very high. Globally, is at about 17%, and it's much higher in the African continent. It's actually in the 20s. And if we are going to achieve the NTB strategy of reducing TB deaths by 90% by 2035, we need to reduce the case fatality ratio to 10% by 2020 and to 6% or less by 2035, which is not an easy task, as you can imagine. And then, of course, the issue of financing the response in such a way that those who have TB do not suffer catastrophic costs. We also have a problem of the rising burden of drug resistance and inadequate testing. At this moment in time, I think the main thing that I want to highlight here is that the proportion of patients who are being diagnosed as new patients with TB, the proportion of those that have MDR-TB is increasing, and I think that's a very worrying trend indeed. We also have problems of weak healthcare systems that cannot deliver the services that we want them to deliver. Services are not integrated. Services are far from where people are. Services are their human resource for health problems. There are health financing problems and all sorts of things that are happening within healthcare system, implying that we need to strengthen our healthcare systems. So what interventions may we apply to confront some of these problems that we are currently facing? Our approach has been primarily a biomedical approach. We want to find all cases, and we want to rapidly initiate appropriate treatment for these cases so that we can reduce transmission. If we reduce transmission, hopefully as time goes by, incidence will start coming down. We want to ensure that we offer universal drug susceptibility testing so that all patients are given appropriate treatment to the form of disease that they have. We want to prevent, find, and treat comorbidities, and the major ones here would be HIV, and there is lots of data now that shows that as we expand ART coverage, TB rates, at least HIV-associated TB rates are coming down. We are not quite sure whether that means less transmission, but at least that is that's a good thing, that ART coverage does decrease HIV-associated TB. We want to look at tobacco smoking and many other risk factors. We need to work around these things. We want to provide an appropriate and supportive environment to ensure that people receive so-called patient-centered care that allows them to be fully adherent to their treatment. We want to manage latently infected tuberculosis so that we prevent progression of disease for some of these people. But that's a big challenge because currently it's estimated that 1.7 billion people in the world are latently infected with TB. So that's a large pool of people that are likely to continue to develop TB, and therefore managing LTBI is really a big task for the community of TB. Active case finding is something that has recently become extremely critical or important in the world of TB. A recent meta-analysis and systematic review suggested that active case finding can do several things for us. It definitely increases case notification, at least in the short term. It finds cases earlier, with less severe disease and so potentially less damage, less post-TB chronic lung disease, for example. Treatment outcomes are no difference between those who are found actively versus those who are found passively, but the impact on TB incidence is unclear. I just wanted to mention two studies that have been carried out in the African continent. The Detect TB work that was done by Liz Cobert in Harare on active case finding at the community level that did exactly what I have said already, and the ZAMSA study, which unfortunately did not show a reduction in TB incidence when it was concluded. So the biomedical approach is probably not sufficient and won't be sufficient to take care of the problem of tuberculosis. We need to do more. And maybe the most important thing that we need to think about is wealth creation and distribution. How are we creating wealth and how are we distributing that wealth? And some people have looked at this process, at this issue. A lot of people are beginning to get interested in this issue in a great deal. And this is a publication that came out recently showing that, in fact, if we were to marry the NTB targets with the Sustainable Development Goal Target 1, which is ending extreme poverty and all those things, then if that SDG Target 1 was to be achieved, it would have a major impact on TB rates in the world today. If we ended extreme poverty, we would reduce TB incidence by 33.4%. If we expanded social protection, we would reduce TB incidence by 75%. And if we were to do both, we would reduce TB incidence by 84%. Now, this would be a major thing if it were possible to do that kind of thing. And it has happened before with the Industrial Revolution in Europe and other parts of the world. TB rates started coming down long before your first anti-TB pill became available. And therefore, it means if that happened then, it can happen again. If people are lifted out of poverty with better social conditions and what have you, maybe TB rates would come down and it would be much easier to achieve the end TB targets that we are all very happy with. So it is important that we all start thinking about poverty reduction. Poverty reduction is probably the major issue that is going to do the job for us as TB people. So to conclude, if poverty reduction and all these other things are important, it means a biomedical approach is not the only way forward, and we need to involve many other partners and many other actors to confront tuberculosis and bring it to its knees. And a multi-sectoral approach, therefore, is what is needed, combining biomedical and biosocial approaches, strengthening healthcare systems, acting across borders, carrying communities with us, remaining very vigilant to be able to detect change and act on it, sharpening our creativity and our innovation. This is the science that is needed to be able to come up with new drugs, new medicines, new diagnostics, and new vaccines, but not just bring these things up, but also making sure that the implementation science is up to date to be able to have these adopted at the country level to improve coverage and for them to make sense at that level. We need to improve technical and managerial capacity and functionality, and all this would require very committed, visionary, and focused leadership at all levels. I thank you very much for listening. Thank you.